Welcome to today's webinar. County Health Rankings and Roadmaps is a program of the University of Wisconsin Population Health Institute. This webinar is brought to you thanks to the contributions of colleagues and partners in Wisconsin and across the nation, with support from the Robert Wood Johnson Foundation. It is produced in collaboration with Healthy Places by Design, an organization that advances community-led action and proven strategies to ensure health and well-being for all. The University of Wisconsin-Madison occupies ancestral Ho-Chunk land, a place their nation has called Dejope since time immemorial. UW-Madison respects the inherent sovereignty of the Ho-Chunk Nation, along with the 11 other First Nations of Wisconsin. This webinar will be recorded. All speakers' views are their own. Guest bios and slides from today's webinar are available on our resource page. We will share a link to the resource page when the webinar begins. Stay up to date on all things CHR&R. Find us on Facebook, Twitter, and LinkedIn. And if you haven't already, sign up for our newsletter by scanning this QR code with your phone's camera. It's the best way to find out about upcoming webinars, our podcast, and our latest tools and resources. Your facilitators today include our host, Erica Burrows-Girardi, with support from CHR&R Communications Specialist, Colleen Wick, and the Collaborative Learning Director from Healthy Places by Design, Joanne Lee. We invite you to continue the conversation immediately after the webinar in our discussion group. Joanne Lee will be our lead facilitator. And watch for a chat from Colleen for details on how to join the group after the webinar.
Welcome to Data and Strategies for Disability, Equity, and Inclusion. My name is Erica Burrows-Girardi, and I've learned so much preparing for this webinar, and I'm excited for you to learn from our expert panel today. The purpose of our webinars is to share successes, lessons learned, and relevant resources. And we encourage you to be open to listening from multiple perspectives as we learn together. CHR&R's webinars reflect the values that we hold as part of the University of Wisconsin Population Health Institute. Values of collaboration, integrity, excellence, innovation, inclusion, and courage. These are the values that we aim to model during the webinar, and we hope that you will too. And with that, I'd like to introduce you to the team that will aid in your learning experience, and we'll start with Joanne Lee with Healthy Places by Design. Hi, Joanne.
Hi, Erica, and hello to everybody in the audience. I'm so glad to be here today to discuss this really important topic. Now, we invite you to join the conversation and engage with us during today's webinar. And there's two ways to engage. You can ask panelists questions by using the Q&A box. So you might want to go ahead and open the Q&A box from your Zoom menu. You can enter a question at any time, and I'll be monitoring the box and making sure that we pull questions, common themes to pose to our presenters during the live Q&A time, and we'll get to as many questions as we can at the end of the webinar. You can also engage with other participants using the group chat, and you're already using it, many of you, to introduce yourselves, but I'll segue over to Colleen Wick, who'll tell you a little bit more how you can use the chat box today to engage.
Thanks, Joanne. Hi, everybody. I'm Colleen, and as Joanne said, we'll be talking about the chat. So you could use the chat to share knowledge with each other or respond to questions that we ask you during the webinar. And as you could already see, our chat conversations tend to be very engaging, very active. So if you find them too distracting, you could simply close the chat window in Zoom. Now, this month we are introducing new group agreements for more productive, conducive interaction during our webinars. Since this is the first time we're sharing our group agreements, I'm going to read them all. So here we go. Number 1, listen actively. So make sure to respect others and do not interrupt. Be mindful when sharing, listening, and engaging to create a learning space for everyone. 2, participate to the fullest of your ability. Individuals in the group will benefit from the inclusion of diverse voices. 3, speak from your own experience and story. So try and avoid invalidating someone else's story with your spin on their experience and generalizing or speaking on behalf of groups, types of communities. For example, use I instead of they, we, and you. 4, lead with curiosity to understand others. Aim to gain a deeper understanding of others' experiences and the issues and systems that impact us all. 5, be conscious of your body language and nonverbal responses. They could be as powerful as words. 6, expect ambiguity and uncertainty. We will not answer or solve all the world's problems in this space. This is a learning space. And 7, be accountable to oneself and to each other. So you have the agency and choice in how and if you engage in this space, and it's up to all of us to create an environment that's conducive to sharing and learning. So that's it. Thanks for your patience, everyone, as I read through these new group agreements. Please do join us in making the chat space welcoming by adhering to them. Going forward, we won't read them. We're just going to post them on our webinar resource page for you to reference. Finally, please know that the views expressed by speakers and participants in this webinar are their own. They do not represent CHR&R or Healthy Places by Design. Again, if you have questions for the panelists, use the Q&A box. Now, I'll introduce you to our technologist for today's webinar, Erin.
Thanks, Colleen. I'm Erin Schulten. I'm today's technologist. So please, if you have any trouble hearing the presentation or seeing the slides, please send us a message in the Q&A box and we'll see what we can do to help. We're looking forward to a great webinar to round out our 2024. We've got a great pair of guests today. So thanks for joining us. I'll turn you back over to our host, Erica.
Yeah, thank you so much, Erin. And thank you all to in the audience for your patience as we went through the group agreements. And hopefully you'll find them helpful as we learn together. I want to start by defining some terms that we often hear in public health. Disability equity is one. It ensures that people with disabilities have what they need, not just to exist, but to thrive. Another term that we've been using in the field more often is disability inclusion. According to the Centers for Disease Control and Prevention, disability inclusion ensures everyone has the same opportunities to participate in every aspect of life, like to the best of their abilities and their desires. Now, disability justice might be a term that's new to you. It was to me, or it is to me. Disability justice acknowledges oppressive policies and practices that have limited people with disabilities. It also acknowledges that people with disabilities, like everyone else, live with multiple identities, gender, race, age, and more. Therefore, people with disabilities may experience discrimination and inequities in multiple ways. Disability justice centers the lived experiences of those living with a disability, celebrating all of their unique identities as it seeks solutions that are rooted in equity and inclusion. So, we're going to explore more about what we mean when we say disability justice in our conversation with our guest today. And we're also going to be discussing how you can access data and shift institutional practices to support disability justice. So, with that, let me introduce you to our experts today. Welcome our guest. Dr. Bonnielin Swenor is a researcher and the director of the Johns Hopkins Disability Health Research Center. Kimberly Tissot is the president and CEO of ABLE South Carolina. Welcome and thank you for joining us on our webinar today.
Thank you so much. Really grateful to have this conversation and to be here.
Yeah, thank you so much. And I do want to just describe myself for accessibility purposes. I am a white woman, middle-aged, wearing glasses and a black blazer, and I have blonde hair.
Thank you so much. I appreciate both of you. Can't wait for our conversation. After our webinar today, we're going to have a discussion group to unpack what you're going to hear today. So please plan to continue this discussion with us. During the video intro, you heard about our discussion groups that follow the webinars. They're facilitated by Joanne, always engaging, giving you the opportunity to share with and learn from others. So Colleen's going to chat out information at the end of the webinar so you can link to the discussion group. Then later on this week, look for the webinar resource guide that we're going to email you. It's going to include links from CHRNR, links that our guests have shared with you, and relevant links shared by your peers in the discussion group. The resource guide, again, will be emailed later this week. And so I'm going to invite Kimberly and Bonnie to rejoin us. And I want to start with you, Bonnie. What is the John Hopkins Disability Research Center? What's your mission and scope of work?
Well, thank you. And also thanks for Kimberly for starting with the visual description. I also want to add mine. So thanks for doing that, Kimberly. I am also a middle-aged white woman with longish blonde hair, also wearing black, which is usually the color of choice of panelists, it feels like. And thank you again for having this conversation. The Disability Health Research Center is really focused on changing the paradigm from living with a disability to thriving with a disability. That's really our tagline. And we're interested in using data and data-driven approaches to achieve that goal. We really focus on health equity as the thing we are trying to achieve, and take a view that all roads lead to health equity. So we're working in spaces like transportation and healthcare, food access, employment, and also in education.
Thank you for starting us off with that description. And Kimberly, I'm going to shift to you. How about Able, South Carolina? Share your mission and scope of work.
Yeah, so we have been a disability-led organization for 30 years. And what we do is we equip people with disabilities to lead their own lives. So we teach them the skills that they need. And usually it's just building confidence because they have skills. We also educate the community to break down barriers. And so looking at education as far as Americans with Disabilities Act, Rehab Act, so the big disability rights laws, but we're also teaching our communities about disability justice, but also the sense of needing belonging and what true equity is when you invite people with disabilities to the table. And we also advocate. So we have been able to pass legislation here in South Carolina, pretty progressive around parenting rights for disabled parents. We just ended some minimum wage in South Carolina. So people with disabilities are no longer paid less than minimum wage or allowed to. And we've done a number of different policies for public health. So, but it's really neat because we are disability led. So it's our community making changes in our community.
Yeah, and we're going to learn a lot more about Able and South Carolina as we go through this conversation. But on behalf of County Health Rankings and Roadmaps, congratulations on getting that policy passed. That is super exciting. So that way, there is no difference in the wages. Kimberly, one of the things I shared with you that I learned was that the CDC estimates nearly 30% of folks in the US, or at least adults, live with a disability. And even with that many people living with a disability, there is still some uncertainty or disagreement about what disability really means. So, what's the official definition of a disability?
Yeah, so the
Can you read it?
definition of disability under the Rehabilitation Act of 1973 and also the Americans with Disabilities Act. So it's a disability is a physical or mental impairment that substantially limits one or more life activities. And so thinking about major life activities, so seeing, breathing, walking, talking, hearing, thinking, those are all what disability is defined as the major life activities. The Americans with Disabilities Act and Rehab Act is very different from the Social Security definition. So Social Security looks at labor and employment abilities, which sometimes I get wrong, but that does not classify somebody as having a disability. So having a disability is when you have one or more major life activities that are limited. So myself, I am a person that had childhood cancer and had a high level amputation. And so I will say, because of my ability to walk, that makes me a person with a disability.
So that's really, really helpful because part of really being able to find solutions is to have a definition that's common, that's across the board, that everyone understands. So thank you for sharing that. And Bonnie, I want to ask you next because in the introduction, I was telling folks a lot about these terms that we have used a lot in public health lately: disability equity, disability inclusion. Why is disability justice the more appropriate term as we think about the types of work that you and Kimberly are doing?
Yeah, this is such, I think, an important concept to push forward in public health. So I'm grateful that you're elevating it. So first of all, disability justice is a construct or a concept that has 10 pillars that really intends to push us from a framework of disability rights, right, towards this concept of justice. And that framework was developed by disability activists of color in 2005, Patty Byrne, Mia Mingus, and Stacy Milburn. And it's important to bring into the space of public health because it helps us understand that people with disabilities are a community of people and that we need to strive not just for being equal, but equity, right? And you introduced that concept in the beginning of equity. I think that, from a lens of public health, historically, disability has been an outcome and not a community of people. And that certainly is a construct that's caused some harm. And so the idea of justice is about, redressing that harm in many ways, but also the concept of justice is trying to address the inequities for communities before they begin. Another really core component of disability justice is, as you very well mentioned in the beginning, is considering the intersectional approach to doing the work and recognizing we're more than one thing. And we need to think about that in the space of disability work too.
Yeah, thank you so much. So in public health, we should be aiming for disability justice with the work that we do. And Bonnie, I want to now talk about how important data is because it's so foundational for planning programs, for planning policy. Uh, yet, I'm learning that we don't have the same data for people with disabilities as we have for others. Why is that the case?
Yeah, well, it's a good question why we don't have the same amount of data or data on people with disabilities where we have data for other communities that face inequities. And, it's really a byproduct of the undervaluing of disabled people in society. Such an undervaluing that we don't even value data collection. In my center, we talk about disability data oppression, which is the concept where we're continuing cycles of inequity and oppression for people with disabilities from all communities, all intersecting communities, by simply not collecting data or collecting data in limited ways. And, as you alluded to, data underpins really critical components to advocacy, to evidence-based anything, right? It's the evidence part. And we are not collecting data on people with disabilities in the same places we're collecting information around race, ethnicity, age, gender identity. The construct of disability, as we were discussing, is not that disability is a demographic, and therefore it's not collected all the places we're collecting other demographic information.
So how do we in public health change that?
Yeah, so I think as public health professionals, it's our responsibility to change that and to first acknowledge that, right? We have the power to do that. And that means really thinking deeply about what we do and what opportunities we have to collect disability data. And so we take a policy of disability data in all places, meaning including data, collecting data on disability, or including disability data everywhere we're collecting data on other demographics, everywhere. And it's only then will we have the needed information and have the power of data to really understand, address, and advocate for change for the complicated web of inequities that people with disabilities face. We also push forward an idea of disability data justice, which is thinking carefully also about the data we're collecting, making sure the data we're collecting is not perpetuating harms, that it's centered on the perspectives of disabled people, and that we are thinking about things like accessibility in the process, in the sharing, in the analyses, and we're including disabled people in leadership roles. And I'm so glad Kimberly elevated that in her organization, it's disability led. You know, that is essential to these conversations, is making sure disabled people are in places of power. And then at state and local levels, you know, there's lots of opportunities to change for public health professionals. Just recently, my center partnered with the National Governors Association, and we released a brief outlining some of that. And, you know, at those levels, the way to make change on disability data can take different forms. Some states have put forward legislation to actually require disability data collection to advance health equity for residents of the state, have recognized the importance of that. And that's one pathway that's been really fruitful, I would say. It also means prioritizing and recognizing the value of of disability data and putting some funding behind it. But there is a huge component of thinking about accessibility along the entire part of the process. And I mean that in full terms. As a person with a visual disability, this is central to me, but it is more than just accessibility for people who have visual and hearing disabilities.
Yeah, thank you for that. You know, the COVID-19 pandemic highlighted deep health inequities across the country. At the same time, it kind of highlighted some opportunities for improvement in policy and systems. So I want to ask both of you, how did the pandemic position your organizations to deepen your work around disability justice? Kimberly, I'll start with you and then I'll go to Bonnie.
Yeah, so when the beginning of COVID, we did not have any disability data as far as who was getting COVID, who was potentially dying, who was being hospitalized. And so we were able to really advocate within our public health agency to, because we know that people with disabilities are at higher risk of some diseases and viruses, but we advocated to make sure that they were prioritized to get vaccinations. That was an overlooked we were an overlooked population, and that is something that we were able to change. But I think overall, what COVID did is really allowed state agencies and really push state agencies to listen to the disability community. They really learned. We've been saying this for many years. We are left out. We need you know, we're part of public health. We're part of everything. We intersect with every population. And so I think that was something that our state learned. We also did specific outreach to multi-marginalized people with disabilities from different marginalized populations, because that was also not being recognized within the public health field. And so really raised the concerns, in rural South Carolina as well, to making sure that people with disabilities were being included. And a great example of that is when the vaccines first came out, you had to actually go to the pharmacy to get a vaccination. Well, their transportation is one of the barriers that people with disabilities face. So how are they going to get vaccinations? And so we advocated for in-home vaccinations, which is very simple. But we kept getting told, well, people with disabilities, if they're home, they're not going to be able to leave their home. But that's not true. They can leave their home, but personal care attendants are often going into the home and providing assistance. And so we had to do a lot of education in that area.
Yeah, thank goodness you shifted the thinking on that. I mean, from it just seems sometimes it's like common sense, but so glad that you did that. And as a native of South Carolina, I know how challenging rural South Carolina can be getting, getting resources to people who live in those rural counties. So, hats off to you for that and just shifting the conversation. And it's a great example of shifting policy and practice so that way people's needs are met. Bonnie, how did the pandemic play a role in expanding your data research?
Yeah, it was so influential, as I'm sure it was for all of us. I had launched the center in October 2019, so we were still new in many ways when the pandemic began. And early in the pandemic, when the vaccine was or the vaccines were still a scarce resource, um, and states were assigning priority lists to the allocation of COVID-19 vaccines. One of my amazing undergrads working in the center, made an observation that had her grandfather lived in a different state, as an individual with a certain type of disability, he would have been able to have access to the vaccine at that moment. And we thought about it and had some calls with our community partners and decided to put together a dashboard assembling the prioritization and the difference in prioritization of people with disabilities and care providers and caregivers across states. We also made sure that information was in plain language and accessible and downloadable. And that took off more than I think any of us could have anticipated. We started updating it every week, and it had more than 2,000 visits a day at some of its heights. But more importantly, what we learned is how the community needed that information and how quickly they were using that information to advocate for policy change. There were advocates in different states who are writing us asking for, more detailed information and letting us know how they were using our data to make better evidence-based arguments in their states or even in their local communities for better prioritization of people with disabilities and vaccine access. We then quickly also got calls around the inaccessibility of the information and the registration sites. And so we developed a second dashboard assessing the accessibility of those. And we saw a lot of change in those spaces too. And so this whole process really shaped and informed as the center continued and really changed so much for how I think about data and the power of it, in that we don't and shouldn't own this kind of data, right? It is our job as researchers to give the data back to the community, and that is powerful. Give it back to the community in ways in which they need it, not how we think it's needed, but how they are telling us it is needed. And that's been such an amazing experience and so much more meaningful than publishing in some scientific journal.
Can I
Go
go
ahead,
after
Kimberly.
you, Bonnie, really quick? I just want to highlight something. Your work is incredible, but also looking at the inaccessibility. So public health, when we say that things were not accessible, what we're saying is websites weren't accessible. So people had to go to specific websites to find where the vaccines are or where testing centers are. And when people with visual disabilities and other disabilities could not access that, they were not getting the information that they needed. And as far as plain language, we had a lot of clients or a lot of people in our community actually not be able to understand the medical terminology that was so complicated. And so they did not know what social distancing meant. They did not understand that they have to wear a mask all the time in public. And so those were huge barriers, Bonnie, wasn't it? It was huge because our community, again, was not getting the information.
Yeah. And I appreciate you really explaining what accessibility means because everybody has their own definition of that. And it's usually from their own lens of what's accessible for them. So thank you so much for breaking that down, Kimberly. And again, for Bonnie, just how you've been able to use those dashboards to create opportunities to make sure people are getting cared for. I want to dig in a little bit more about the dashboards because there's lots of data that you are collecting. So what types of data are you collecting and what what's missing? Like what is still needed for us to make informed decisions regarding disability needs?
Yeah, so we've expanded on our suite of dashboards, and we have a dashboard looking at how disability inclusive and accessible, and thank you, Kimberly, for that explanation. The process of enrolling in SNAP or food stamps, the Supplemental Nutrition Assistance Program is, and how accessible and disability inclusive information about public transit systems are to help people with disabilities plan. People with disabilities have to know before we go on using public transportation because unfortunately, it's too often it's not designed for us and we have to make decisions. We can't just show up and expect it to work for us quite yet. We have dashboards on universities. The center has so many students who are struggling in the academic setting, and so really wanted to put together a dashboard on how accessible and disability inclusive different universities are. And all of this is really geared towards, again, this idea of democratizing data or information, making data and information open and accessible in accessible formats and giving it to individuals and communities that perhaps wouldn't have access, and that we hope is empowering and driving change. The data we don't have is central to all of what we're doing because the metrics that we're often developing in this process don't exist. And so we're very mindful of the fact that we don't have data infrastructure or systems and structures that collect in a standardized way and share information on how disability inclusive or accessible environments are, policies are, systems and structures are. And so what that means is that people with disabilities are stuck in this cycle of a reactive posture, meaning our only channel to making change are lawsuits and complaints. And those unfortunately lead to micro changes if successful, which isn't an equitable process in of itself. So the data we're missing are all the data we need, to be honest with you, to move to our more proactive approach to disability justice, meaning if we had better data on these aspects of life, then we could understand where and when things are working and share it with the community. And then people can make their own choices, decisions, advocate how they need to. And hopefully that would lead to better, bigger change.
Yeah. And I love what you're saying about data being powerful. It really is. I mean, so many our decisions that we make are always they hinge on data. So and thank you for the dashboards that you do have. Like you said, you've been able to expand them. There are going to be a link to the dashboards in the resource guide. So I'm excited that our audience will be able to get in there and dig around and see what you have. Kimberly, my next question is for you because when what are the barriers to inclusion for people with disabilities. And I'm not talking about what we typically think of. We typically think of um, those of us with ableism lens or ableism mindset, we may think of, oh, we need to have curb cuts or we need to have an elevator in the building. What are the barriers to inclusion for people with disabilities that we often don't think about if we are using a lens of ableism?
Yeah, so we've done a lot of needs assessments, and this is a repeat year after year after year. And I'll say perception. So that ableism, that ableist perception of people with disabilities is really what gets in the way. For example, when kids are born with disabilities, their doctor tells the family that they can't work, they're not going to be able to do a number of different things, versus really changing the script, changing of how to, what are disability rights, the rights that your child will have, the accommodations that are available, the assisted technology that is available, and also just linking to the disability community as well, so that these parents can learn from disabled individuals. But that is, I think as a disability-led organization, I think that's what is so powerful in our work as well, is that we learn from discrimination, our staff. So we create programs around some of the barriers that we see, not only with the individuals that we serve, but also our staff. And so great examples of that is, I'm a mom. I was told that I could not adopt a child because of my physical disability. Well, we ended up changing that. They did not know who they were talking to. But we ended up going and helping pass legislation in South Carolina called the Persons with Disabilities Right to Parent Act. And that act was because not only was it not only my concern, and we did adopt, by the way, but it wasn't not my concern, but we kept getting calls that children were being removed from parents on the basis of disability. So people judged another person and said they can't parent. They can't parent because they're blind. Well, they can parent. They've been adapting their whole life. And so it's a lot of education. And so that is something that I would love to see in my lifetime, of changing the ableist perspective. And ableism is comparing people with disabilities to non-disabled people. And so non-disabled people are the norm, or and the hierarchy. So we're always compared to individuals that don't have disabilities. And that is not something that empowers us. That is not anything that promotes disability pride. So that is, we've got a lot of education to do.
Yeah, and I love how you're saying we've got to shift that narrative, and that's a big start. Is that narrative that can be, the dominant narrative that they're seeing things from a limitation standpoint. So, but Bonnie, I want to shift it back to you because policies and system change, like we were just talking about with Kimberly, are foundational to creating equity. So we policies are just so important. Can you share a few examples of how the data in your dashboards have informed a policy or practice decision?
Yeah, sure. I just want to first say, Kimberly is a very powerful story. And, a lot of the work that we do as a center is motivated by, personal experiences, I think, for many of us, right? And I've been told across my career more often what I can't do or shouldn't be doing than what I can do. And it's always such a striking conversation, including in our dashboards. So, yeah, it's sometimes a little bit hard or uncomfortable for me to draw a straight line between our dashboards and some of the policy changes that came. But I just want to first elevate that our dashboards aren't perfect. And we hear that often, and we welcome the feedback and want the feedback. But we view it as a first action towards a longer goal of building data infrastructure where data infrastructure doesn't exist. We're not the best, and we don't always get it right, but we fight like heck using the data. So during COVID, our first dashboard on the allocation of prioritization of COVID vaccine for people with disabilities. Less than 24 hours after we launched that dashboard, again, to my surprise, the National Council on Disabilities, which advises the President and Congress on disability policy, cited our dashboard actually in a letter to the National Governors Association. So interesting circumstance. We now just put out a policy brief with the National Governors Association. So it's full circle. That was wonderful. And then the White House had convened a committee on COVID-19 equity, and my colleague Kara Ayers at the University of Cincinnati, who is our partner on this work, was invited to present about our dashboard, which was wonderful. The work we did on the accessibility of information and on registration for COVID-19 vaccines. We got a call from folks in the federal government who were designing the vaccines.gov website before it was launched in the early stages. So that was kind of fun in how, we had some opportunities to give some insight there. But not too long after that, and again, we were not the only ones in this space, the Department of Justice took some action on websites, on vaccine registration websites that were not accessible at large pharmacy and grocery store chains. And there was some conversation that mounting evidence around the barriers that people with disabilities were facing contributed to that. HHS also put out, the Department of Health and Human Services also put out some guidance on how to promote vaccine equity for people with disabilities. And that certainly came from good work from advocacy groups that like Kimberly runs. And there was some interest in some of the data we had put out on the perhaps deprioritization of people with disabilities in some of the vaccine queues or lines. So that's, related to vaccine and to COVID-19, which was a bit of a whirlwind experience. And again, I don't want to pretend that our work, was the pure driver of any of these things. It was teamwork makes the dream work, as they say. And so many of us were fighting really hard. It just was a great opportunity to bring some data to the conversation.
Yeah, no, it's fine for you to brag about everything you've done. Thank you. Kimberly, I see we're running short on time, but I want to give you a chance to talk about some of the policies and programs and some of the practices that have shifted in South Carolina as a result of your advocacy work at Able South Carolina. And I also am hoping that you can expand a little bit about this mantra that I saw on your website, nothing for us without us.
Yeah. Yeah, so I'll talk with you a little bit about what we've been able to change in the public health sector. And in South Carolina, we have a statewide task force that is a disability public health task force that we bring everyone together in all state agencies and all private entities focused on public health. We bring everybody together to really look at the challenges that are facing people with disabilities. And so looking at policy change, while we did not have any medical rationing in South Carolina, we were very afraid of medical rationing because our policies are not in compliance with the disability rights laws. And so we've been able to rewrite the law, the policy around medical rationing to take away that disability is not a reason to not give life-saving support. We've also, our influence also helped significantly with creating the DEI office within public health, which is interesting. But they not only have a DEI that includes disability, but they also have an Americans with Disabilities Act coordinator. While all state agencies should have these, larger state agencies should have these, this was a big move because the department is really committed to getting it right. We have a number of grants together from CDC Foundation around health equity that we are doing together to partner to be able to benefit from each other. And so looking at how they can benefit from the disability community and how we can also get information from them. So it's been a great partnership and relationship. So, and then as far as nothing about us without us. And so if we go back, ableism kind of takes over society. People with disabilities even have internalized ableism sometimes because they're picking up ableism from other people. What nothing about us is, without us means is if there's a policy, if there's programs, if there's anything about people with disabilities, the disability community should be there. And if somebody is talking about an individual, that individual needs to be there with a disability. So often, without the disability perspective is when programs just don't work. They're discriminatory. Usually they're rather ableist because they're not having anyone to track that. And quite frankly, a lot of the programs do not work when they have not had disability input. And so a lot of times people think that they know more about disability than the disability community because they learned it from a textbook or read it on a website. And that, lived experience that's a data point that I would love to see just some research around the lived experience and how powerful that is to be able to shape policy and programs. And so
Well, thank you so much to both of you. And I appreciate your stories, your advocacy work. You are truly just champions of this work. And we have been so grateful to have to allow you to be able to be on our platform to just share your work. So thank you so much. As you are working in working in the areas of disability justice, I want you to think about these next steps. Explore your organization's policies and practices. Do you even know if they support the needs of people with disabilities? Those are things that I would challenge our audience to explore. Were people with disabilities included in creating them, like Kimberly was just talking about? And always aim for disability justice. This way, you are looking to address or redress harms and oppressive practices that people living with disabilities encounter. And lastly, adopt that mantra, nothing for us without us. Be sure to include those with disabilities in all decisions and practices. And then explore these what works for health evidence rated strategies as you think about those next steps and what those next steps might be. Social service integration, and rural transportation services. You heard Kimberly talk about how difficult transportation can be, or those transportation needs are just really, really high when you are in a rural area. So, as a reminder, County Health Rankings and Roadmaps, What Works for Health Database contains about 400 strategies to support you in your community improvement efforts. So, be sure to check it out. And so, with that, I'm going to turn it over to Joanne to see what questions may have popped up.
Thanks so much, Erica and Kimberly and Bonnie. You've definitely got people's brains working. Lots of questions coming through. We'll try to get through as many as possible. So with that, I would just ask that you try to keep the responses as concise as possible so we can get to as many questions as possible. And knowing that folks can come to the discussion group if they want to kind of unpack a little more involved questions. So I'm going to start with, I think is hopefully a kind of straightforward one with Bonnie, and it's about the dashboards. People are so excited about it. And Emma wanted to know what analytics system you use to create the dashboards. They're working on dashboards, so want to get some insight on that.
Such a good question. Honestly, the answer is that the back end differs for each dashboard. So I don't have a solid answer. That's simple. I will say one thing. We had essentially no funding for any of them, which
Wow.
is something. We got $4,000 from American Association of People with Disabilities for COVID work. No one wants to fund this work. So it is shoestring on the amazing work of our students and trainees and their commitment to making change. But
But it's possible. All right. Thanks for that. And I'm going to, we heard a lot about how a lot of work in advocacy is needed around making sure we're actually capturing good data and good indicators around this issue. And so it sort of led to the question, are there any recommendations for what kinds of questions to use when we are trying to collect data on disability for public health on a population level? Folks have been wrestling with this, and it doesn't appear, as you all have said, doesn't appear to be consensus or even on good measures. So what kind of maybe your top 2 tips from each of you would you give for those that are still needing to do work?
I will give 2 tips. And so one would be, not only phrasing the questions, but how you deliver the questions. Sometimes survey monkeys are not going to work. Surveying people electronically is never telling the whole story. So consider doing a verbal survey and or interviewing individuals with disabilities. And then also I would definitely partner with somebody, the disability community in your area, to help look at the questions as well, to make sure that they're understandable and also culturally appropriate for people with disabilities. And so there's a lot of words that we do not say that non-disabled people created for us. And so that would be a great benefit to you if you did partner with a disability-led organization like Centers for Independent Living. We are a Center for Independent Living.
Great.
Yeah, such a great question. And anyone who's curious about this should perhaps review what's happened over the past year at a national level. So there's been pushback with the Census Bureau. We've come to good progress now on questions on disability. So for history, the Affordable Care Act set a standard that disability should be collected as a demographic and actually puts forward 6 questions to collect information on disability as a demographic. They are not perfect. They miss people. Let me be clear. We have evidence on that. We do not have an ideal set of questions or measures, and that's a problem. And it's a problem we have because this is an area that's been underfunded. But it's the best we got, and we promote what we call a growth mindset on disability data, to use those 6 questions and then as a core consider adding. The state of Oregon has done this and done a pretty good job on this. I'd say a really good job on this. So look to Oregon as a state. They've passed legislation requiring the collection of those 6 questions plus others to have that information of disability as a demographic to promote health equity. And really got that legislation passed on the back of the Affordable Care Act. I know that might be in flux, but that's the history.
Yeah, very, very helpful. So now I want to shift gears a little bit because in addition to sort of some of the challenges with lack of good data and consistent ways to collect them is the issue of how are we actually defining persons with disabilities. And there were some examples of things that might be more apparent just by if somebody has some visual cues. Um, but some folks wondered, just generally, do you feel like folks with disabilities, such as psychiatric disabilities or conditions or things that are not as readily seen outwardly, um, just comment on is that an additional challenge or what should people be keeping in mind to make sure that they are being as inclusive as possible?
Yeah, and I think it's overarching categories of disability of what you should include. So, mobility, physical, you can, vision, hearing, hard of hearing. So different categories. But I would not list out specifically the disabilities because it's so, there's probably a never ending list of different diagnoses, but I would focus on kind of the overall categories. As far as people with psychiatric disabilities, they are very important to our community. They are part of our community. And so we always try to include them, but that is often not recognized as a disability for some reason. So we're always providing that education because people often do not know what actually disability means. They'll say, "Are you on Social Security?" And maybe they're not. We don't want people just on Social Security. We want them to work. And so going back to, that ableism, those questions, but
Thank you. Bonnie, you want to comment on this?
Yeah, from where I sit as in working in measurement development, right, centered on principles of disability justice, again, I'll just say we have a lot of work to do in this space. The data standards we do have right now are inadequate and insufficient, and that's just the truth, and that's just the reality. And the conversation is, how do we get to a better place while not ignoring where we are now, right? And, the advice I always give is, let's use the data we have, fully understand the limitations and the groups that we're missing with the data standards we have, but with equal fervor, work towards creating better disability community-centered measures of disability that are more inclusive. And that's just the hard truth of.
Yeah. Well, along those lines, some of the ways that we talked about collecting good data, you both are really bringing everyone back to the fact that you have to include people who are most impacted in the process to make sure it's being as inclusive as possible. And so this is an opportunity to, I think, reinforce maybe some more specifics around the how do we do this, because a few people are really picking up on this piece that we're really relying on people with disabilities to disclose and self-report, right? And there might be some hesitancy to do that. So can you each comment about what can we as practitioners make sure we're aware of to make sure that there's, not so much of a concern around the need to disclose and self-report?
Yeah, when I say trauma, the disability community is often traumatized by retaliation and different discrimination. So we do want to make sure that it is normalized by putting it in a demographic to be able to answer, because that would be so helpful, and that would really bring awareness to public health entities. Sometimes we hear we don't serve people with disabilities. Well, you probably do. You're just not asking the questions, and you might not know that definition of disability, but you probably do. But also having a welcoming environment. Are you accessible in the first place? Have you explained people's rights, and that the organization and agency will not retaliate on the basis of all of the EEOC basis, the protected classes, sorry. So that is the key, but you have to carefully word it, and because people with disabilities are scared, and then there's so much ableism that we're afraid of the bias.
Yeah, thank you so much, Kimberly, for elevating those points. Data and society have a two-way relationship, and we don't often think about that, right? And to Kimberly's point, when we don't collect disability data, that sends a really clear message to our community that we don't matter, and we don't matter to such a degree. We're not even going to collect your data as part of our demographic information. That being said, there's a lot of fear that we here as a center doing this work around, is that information going to be used to attack my eligibility for certain benefits programs and activities? So there needs to be, first of all, that trust building. We need to include people from the community as leaders doing the data work. Let me be clear, on the data side, on all parts of the arc of this process, in positions that have real power, because that's essential to building that trust and establishing that culture where people feel comfortable. I often hear from certain entities that they don't want to collect this data because they feel it will bait a lawsuit or no one will answer truthfully. But think about then the message you're sending when you're not even asking those questions.
Yep. Thank you both so much. There are a lot of questions that we just couldn't get to, but I think we answered some of the main or common themes. And remember, folks, you can come over to the discussion group to continue the conversation with Kimberly and Bonnie. I'll turn it back over to you, Erica.
Just so much love in the chat for people that are expressing their gratitude for you sharing this information with us. So, yeah, it does help to unmute. So anyway, Colleen has probably already chatted out a link to the survey for this webinar. Please do take some time to complete it sometime today and let us know what you think, because we read your surveys, we read your responses, and it helps us determine which topics we want to bring on our platform too. So every year, County Health Rankings and Roadmaps observes the National Day of Racial Healing with a webinar that connects truth, healing, and reconciliation to health. And I am so excited that next month webinar will feature the president and CEO of the Oglala Lakota Nation, Nick Tilson. So together we're going to explore the role of land acknowledgements and ancestral land returns in health. So please be sure to join us. You can actually register for that webinar right now on our website. It's going to be a great one, just like this one was. And I'm asking Colleen to go ahead and chat out the link for the discussion group where you will be able to have some little bit more one-on-one conversations with Bonnie and Kimberly, as well as other people in the audience who can share some of their experiences and the work that they're doing around disability justice. So thank you for all that you do. Please stay connected to us. We have a presence on social, but the best way to get to learn about all of our resources and upcoming webinars is to subscribe to our newsletter. So please be sure to do that. Thank you for joining us for this last webinar of 2024. I'll see you in a discussion group or in 2025. Thank you.